It seemed to me.
Hello, everyone. I'm Betsy Nicoletti. Thanks for joining me today. This is our final of the coding education sessions, the fifth of 5 of them. And we're going to talk about coding for minor surgical procedures. In primary care, either you love doing doing surgical procedures and you do a lot of them, or you really don't like them at all. But most of you probably do some of the procedures that I'm going to talk about today. And if you do like doing them, one of the things that's most important is to have a room that's set up with everything that you need in it and a staff member who knows how to assist you. Otherwise, the 7-minute procedure becomes a 27-minute procedure. The first item on our agenda is whether we're going to bill an E&M, a level of service, and a procedure, or a procedure only. This must have been 15 years ago. I was meeting with a primary care clinician, and I'd been reviewing some notes, and I said to her, you know, Dr. Hernandez, you could have billed both an office visit and a procedure for this service. I don't remember what the procedure was. And she said to me, Betsy, it would take too long for me to find the code for that procedure, so I just billed for the office visit, which was unfortunate because, of course, she had done the work. But the first thing that we'll talk about and that we'll weave our way through as we talk about specific procedures is whether we're going to select a level of service and a procedure or just the procedure. And then we're going to look at some of the procedures that I have listed on the slide. And if there are any other procedures that you have questions about that you do or that you're thinking about doing, please ask those. You can put those in chat or unmute at the end. Some of the codes that we're going to go through have a plus sign in front of them. That means they're add-on codes. They can only be added to a related or base procedure. We would never code them on their own. So this is from the National Correct Coding Initiative Manual. And I hope it's the only paragraph that physicians and NPs and PAs need to read from that manual, because it's really for us, for coders. The decision to perform a minor surgical procedure is included in the payment for the minor surgical procedure and should not be reported separately as an E&M service. So when I read that, I think, oh, if I've seen a patient, if you've seen a patient and decided to do the procedure, we should never bill an E&M service. However, a significant and separately identifiable E&M service unrelated to the decision to perform the minor surgical procedure is separately reportable with modifier 25. So in the second sentence, they basically contradict the first sentence. So the first sentence says, don't bill us a separate E&M, and the second sentence says to bill an E&M. Both this manual, which is published by Medicare, and the CPT book say that you don't have to have a separate diagnosis. Now, when I was out working in the field more, coders and billers would tell me, oh, the payers require a second diagnosis in order to pay for both on the same day. That shouldn't be the case. You should be able to use both. I'm going to give some examples about when we'll bill just one and when we'll bill the other. So we're going to bill both when the physician or PA or NP needs to evaluate the patient's symptoms, condition, or problem prior to doing the procedure, and really decides to do the procedure at this visit after the evaluation. And both are documented. When you think about a procedure, and we think about the payment for a procedure, which I know you're not spending your days thinking about, a procedure has some pre-work involved in it, the work of the procedure, and post-work. And the pre-work is explaining the procedure to the patient, getting verbal consent, getting the patient positioned if that needs to be done before the procedure, and then explaining to them afterwards what the follow-up care will be or what to expect. So that is all included in the payment for the procedure. But sometimes a patient comes in with a complaint and it isn't clear, it isn't completely obvious that a procedure is what you're going to do. So a patient who comes in with dysfunctional uterine bleeding and postmenopausal, maybe cramping and pain, you evaluate the patient and you're thinking about whether you're going to do an ultrasound or some other diagnostic test, and you decide to do an endometrial biopsy. If you do that endometrial biopsy today, you bill both for the E&M service and for the endometrial biopsy. If you say to the patient, if the patient says, I don't want to have it done today, my cousin is going to be able to drive me if I come back next week, and I need to think about it or worry about it for a week. When the patient returns for a planned procedure, you bill just for the endometrial biopsy, even if you go over a lot of the things you talked about before. Joint pain is another example. You have a patient who comes in with either new onset or gradually worsening knee pain, and they have a diagnosis of osteoarthritis. And at this visit, you say, the nonsteroidals aren't holding your pain and the exercise and the other things that you're doing. So let's do a steroid injection. And the patient agrees. You bill them for the E&M service. You have evaluated their knee pain, their osteoarthritis, and then you make the decision to do the procedure, and you bill for both of those. If the patient comes back in a week for some reason, a planned procedure, we bill only for the procedure. Another service that I frequently see billed with both a level of E&M service and a procedure is I&D of an abscess. Often that requires an assessment, talking about fever, thinking about whether antibiotics are needed or not, and the procedure is done. It's easier if you have separate diagnoses. So if you were seeing the patient for an E&M service for hypertension or osteoarthritis, and they said, oh, by the way, I've got this, lesion, and it was a wart or an AK, then it's easy because then you can bill for the office visit and the procedure, and you bill the office visit with the hypertension and the procedure with the wart destruction. Of course, you're being paid the PPS rate for all of these things, so it does get bundled into a single charge for the patient, but we're still reporting the work that was done. So if you've done that minor procedure, we're still adding that minor procedure to the claim form. It's just that the qualifying visit remains the same and the payment to the organization remains the same. But we want people to know the work that you've done. So we're going to bill only for the surgical procedure for when only a procedure is documented. Where I used to see this the most was back when we had paper records, and the patient would come in for a colposcopy, and there would be, the image of the cervix and the vagina, and the clinician would write a few things on it, and where they had taken the biopsies. So they weren't just writing random things on it, and bill for an office visit and a procedure. Really, that only documented the procedure. And that still can happen in an electronic health record when you say, oh, the patient comes in because they've got plantar warts on the bottom of their feet, and we treated them. We're billing just for the procedure. That still qualifies you for a visit in an FQHC. Probably the wound debridements are going to a wound center. We hope so, because they're not anyone's idea of, well, the wound people like to do them, it seems. But if you have a patient who you see, you evaluate for a non-healing wound and you debride the wound, and we'll look at the code for that. And then you say, we're going to have you come back in X days. We're going to need to re-debride this wound a second time. When they come back for that planned procedure, we only bill the procedure. Basically, when the medical decision-making occurred at a prior visit, only the procedure. And then including a biopsy. And then the payers can be just difficult about skin procedures. So even though the rules aren't any different, sometimes they just won't allow both at the same time. But you put down both things if you've done both things, and then the revenue cycle department will figure out what we're going to get paid for. They're also going to add modifier 25 to the E&M service. And we add modifier 25 to show that there was a significant and separately identifiable E&M service on the same day as the minor procedure. You don't have to worry about that. The revenue cycle staff will take care of that for you. Sometimes that comes up and you see it, that's what it's about. So removal of a foreign body from the skin. We have two codes for that. One is simple and the other is complicated. And it's incision and removal of a foreign body subcutaneous. CPT doesn't define simple or complicated anywhere. So it's your judgment. If you do some of them and you take that sliver right out, I guess, let me not say sliver. If you take that fish hook right out and you need to do an incision and you pull it out and it was straightforward, the way most of them are, use the simple one. If there was excessive bleeding, if you had to make a deeper incision, you're thinking now, I wish I'd sent this person to urgent care, document that, we'll do that as complicated. If all you do is remove the sliver, then we don't get to bill this code because it's incision and removal of a foreign body. Here in the Northeast, where there are a lot of ticks, when you go in and they just pull that tick right out, if it's someplace you can't reach so you can't take it out yourself, we don't bill incision and removal. It's part of an E&M service. And then sometimes we're removing a foreign body from somewhere else. These are the most common ones. If you see kids, the two at the top, taking something out of the ear and taking something out of the nose. And then the ones at the bottom, if they're in the eye, typically those are going to urgent care, primary care, or to ED, but there are codes for those if you do those in the office. Incision and drainage of an abscess or a cyst or a furuncle, all of those things, is divided into simple or single and complicated or multiple. And I can tell the difference between single and multiple, but between simple and complicated, CPT again doesn't give us a definition. I often see these billed with an E&M service as well. But if you did this today, and then the patient came back in 5 days and you redid it, it might be less likely that you would need a second E&M service for the service because you'd already evaluated the condition. This is the code for wound debridement. Now, some of these, I know you have coding staff, and if your eyes are glazing over, I'm never going to look up the codes. I'm never going to remember how many square centimeters. These are the kind of things that it is good to get help for. If you do a service 3 times a month or 8 times a month, I don't know if anybody's doing an IND that often, but if you're doing an IND fairly regularly, you can probably find the code for it in your EMR. If it's something you're doing twice a year or 4 times a year, rather than you spend 2 minutes looking for it, it'd be great if you could just ask coding to find that code for you. So wound debridement 11042 is for debridement of the epidermis and the dermis. So the wound debridement codes are by depth and square centimeters, not by location. We're not going to be doing in our primary care offices debridement of the muscle and fascia or bone. Of course, those are going to general surgery, but sometimes I do see these done in the office, the epidermis and the dermis. If you debride one from the upper right arm and one from the lower left leg, we add together the square centimeters for those to come up with the total. And there's an add-on code for each additional 20 square centimeters or part thereof. So if it's 20 square centimeters, it's one code, 11042. If it's 21 square centimeters, we get that add-on code. And again, get help with looking some of those up if you're not doing them frequently. Biopsies, there are just so many ways you can do a biopsy. And I haven't, of course, included all of them, but we're going to talk about some skin biopsies today. I didn't include all of the biopsies that there are in the CPT book. If you're one of these clinicians who likes to do a lot of them, again, you want to maybe get some support for that, some reference sheets. These biopsies that I'm going to talk about on this page are You take something out and you send it to for pathology, where we're also going to have shaving of lesions, which may or may not go to biopsy, and excisional removal of benign and malignant lesions. Of course, if they're malignant, they're going to biopsy, but if you're removing a benign lesion, an excisional removal, that's not actually defined as a biopsy. But let's start with these. Punch biopsy, the 2 codes at the top, they got deleted, and they replaced them with 6 codes. This is typical of CPT, and it's why the book gets heavier and heavier every year. They take out 2 codes, they add 4 more, so now I have a total of 6. So these are skin biopsies. They are not defined by location or size. So you already know if you're doing something bigger, you're probably going to be using a different code. But these are not defined by location or size. They all include simple closure, and we report each lesion. So if you do 5 of them, we're going to report all 5. The first 2 are the tangential biopsy, shave, scoop, saucerize, or curette, where you remove a sample of the epidermis tissue with or without the underlying dermis. If you did 3 of these, you'd bill 11102 once and 11103 twice. Then the punch biopsy, which you use the tool for, even if that needs a stitch, you don't get to bill for the stitch. And the incisional biopsy, which is a wedge-shaped biopsy. So those all assume you're going to send those off to pathology. And none of these are paying attention to margins. When we're thinking about margins, there's a different set of codes. Shaving of epidermal and dermal lesions. Shaving is the sharp removal by transverse incision or horizontal slicing to remove epidermal and dermal lesions without a full thickness dermal excision. Now, you could be just shaving something and not intend to send it to biopsy because you look at it and you say, well, I'll just take that off for you because it's bothering you, but it doesn't have to go anywhere. It includes local anesthesia if you need it and cauterization if you need it. You don't get to bill for that separately when I say it includes it. And these codes, and if you don't have your handout, we'll make sure everyone gets a handout. Some people yesterday didn't. It's in the full big handout that IHP sent. And if you like doing minor procedures, you're going to love the handout. If you don't, well, there's always, you can use it for kindling, right? So these codes are defined by location and by the size of the diameter of the lesion. So where did you take it off? And how big was the lesion that you shaved? Now, the excision of benign and malignant lesions, of course, naturally don't use the same measurement because here we're using the measurement of the size of the excision, not the lesion. So it's full thickness removal of the lesion, including margins, and the intent is to get the margins, which, sometimes we do and sometimes we don't, but that's the intent of this. So you're taking out the lesion and margins around the lesion. We select the code by the size of the excision, the longest clinical diameter of the lesion, and the narrowest margins. So if we had a perfectly round 1 centimeter lesion and you did a 1/4 inch margins all around, we would use a 1/4 inch for the first margin plus the lesion 1 centimeter plus another 1/4 inch for the margin. You add those 3 numbers together and that's the size of the excision. If you do a keyhole excision, we don't take those big margins that are part of the keyhole. It's the narrowest margins. These codes are defined by size, location, and if the lesion is benign or malignant. So in order to select the right CPT code, I need to know if it's a benign or malignant lesion. So of course I have to wait for pathology, but this is the only set of codes that we wait for pathology for. For other biopsies, we don't wait, and we just send in this code D49.2, neoplasm of unspecified behavior of bone, soft tissue, or skin. We don't use, it's really easy. Of course, we coders, we keep saying, no, don't use unspecified. There's a code for uncertain behavior. We don't use that code. That's the code for the pathologist if the pathologist is uncertain. So for all the other biopsies, use D49.2. For these excisional biopsies, we wait until we get the pathology back because that's how we choose the CPT code. The principles of CPT coding do say, though, that if it's obviously benign, you can bill it benign at the time of service. You don't have to wait. And that if you're re-excising a malignant lesion, which I know mostly is derm and general surgery, if you're re-excising it, it's because you didn't get margins the first time, then you use a malignant excision of a malignant lesion, even if pathology later shows it's not that you got the margins this time. All right, so I've taken it out. I've taken a biopsy, I've shaved it off, or I've excised it. So how about lesion destruction? And this is my favorite term in the CPT book, because as a patient, we all go in and say, I'd like to have this lesion destroyed, please. So CPT says lesion destruction is benign. It's the ablation of benign, pre-malignant, or malignant tissues by any method. There are a few codes that where the method is designated in the code, but not most of them. So when we're doing a destruction of a benign lesion, we start with location, and there's skin, and then there's what I like to call the sensitive areas. So if you're doing destruction of a benign lesion of the mouth, eyelid or margin, conjunctiva, vulva, vagina, anus, or penis, then we have a different set of codes that we use. And these are listed in detail in the handout. So for a benign lesion, we need size if it's on the eyelid or margin. We're probably not doing those. Simple or extensive for vulva, vagina, anus, or penis. So, if there are 2 of them, we're probably going to call that simple. If there are a lot of them, and CPT doesn't tell us what the difference is, but if they are extensive, then there's a different code, and you're going to want to document the approximate number that you've done, or the actual number if you can. For destruction of benign lesions on the anus and the penis, that's where method matters, unfortunately. And then for skin, we have different codes for pre-malignant lesions, benign lesions, and skin tag. And there is a chart in your handout. So if you didn't get the handout, we want to make sure that you do. So we need to contact your practice leader or someone to get it, because there's a single page chart, a reference sheet for destruction of benign and pre-malignant lesions, which I think can make it easier than looking at these slides. And it includes the codes for mouth, vulva, vagina, anus, penis, and for penis, it's by type. For simple and for extensive, it's any. So if you are doing those services, you want to print out that one chart so that you can easily find it. All right, now how about lesions of the skin? So we're going to start with pre-malignant skin lesions, an AK. And here CPT has defined it as the first lesion, 2nd through 14 lesions each, or 15 or more. So you would never bill 17004 with either of those other 2 codes on the slide. If you did 5 AKs, you'd bill 17000 once, 17003 4 times. If there were 15 or more of them, then we bill the 17004. I never see that many done at once. For warts, we have a different counting system, and here the code is just defined as benign lesion. So I've put the word warts in there because that's what we use. It's other than skin tags or cutaneous vascular proliferative lesions. And skin tags has its own code for destruction. It's in the handout. It's often considered cosmetic. So if you're going to do it for a reason, it rubs against someone's clothing or waistband, then you want to make sure you document that. If it's irritated or bleeding or is causing a problem. Just increases the likelihood that the payer won't say, oh, that was cosmetic. Destruction of malignant lesions, we're not doing them, so I just put them in for completeness because we've destroyed everything else. These are selected by the size of the lesion, not the defect. These are selected by location and method of destruction. They are in the handout if you need them. So now let's talk about just a few orthopedic musculoskeletal type services. So the first one is injection. And notice there's an S there for injections. That's tell us if you do one or more in a single tendon sheath, ligament, or aponeurosis, one or more, you're going to build 205501. So plantar fascia is one example here. And that's when it's a broader code. It's anywhere along the tendon sheath or the ligament that you might do that injection. And again, if you do two of them along the tendon sheath or the ligament or the aponeurosis, that's considered one unit of 20550. 20551 is when it's a single tendon or origin on the insertion point. So where the bone meets the knots of muscles. 20552 injection, single or multiple trigger points, one or two muscles. Here they're making it really clear. If it's one or two muscles, no matter how many injections you give, you build that once. And it has to be three or more muscles, 2055, to build 20553. The next set of codes are the joint injections. These are the ones I see done very frequently by both family physicians and internists. So a lot of times family practice doctors will, and NPs and PAs will do more procedures than internists, but these are ones I see that the internists will do as well. It's injection, it's arthrocentesis, aspiration, and/or injection. I sometimes get asked, if I aspirate first and then I do an injection, do I bill that twice? No. If you're in the same joint, you're going to bill one injection. And these are defined by small, intermediate, and major joints. And they're defined with or without ultrasound guidance. If you're using ultrasound guidance, we need a permanent recording. That means we have an image of it. You know, we've snapped an image. I can only picture that like on my phone, snapping an image, and we keep that in the medical record, and you describe what you did and why you did it using the ultrasound guidance in your procedure note. So we've got the injections of the small joints. Maybe we don't do those quite so frequently. The intermediate joints, I won't read them all to you. And the ones I see done most frequently in primary care are the major joints. Shoulder and knee are the ones I see most frequently. So we're not allowed to report ultrasound guidance with those codes because they gave us 3 new codes a few years back that included the ultrasound guidance. You want to document why you used it. I used it to better visualize the patient's anatomy, whatever the reason was. And there needs to be this permanent recording, this image. And we're not doing a separate report like a radiology report, but you're going to write in your procedure note using ultrasound guidance I, X, Y, and Z, so that that's included in your record. I'm going to talk about a few. This code's back from the skin section. It's implantation or removal of an implantable drug capsule. So specifically 11976, removal of a contraceptive capsule. 11980 is a little broader, defined. They didn't put them in the book in the same year, so they're probably why they're described a little differently. Subcutaneous hormone pellet implantation beneath the skin. If you saw a patient and did an annual preventive medicine, you did a well woman exam, and at that visit, you talked about whether or not you talked about the type of contraception the patient was going to have, and you decided on this implantable capsule. When the patient returns, and you schedule that for the patient, when they return, we're just going to bill just for the procedure. Of course, we're going to have to attach it to a qualifying visit, but you're going to select this code that describes the service that you've done because you've made the decision to do it already. And that's similar to an IUD insertion and removal. So we've got codes for insertion and removal. You can bill them both on the same day. So if you have a patient who needs to have an IUD changed, it isn't working, it's causing pain, having trouble with it for whatever reason, you can bill for both of those on the same day. And the IUD one is a little more complicated, but it's the same concept. You saw the patient at their annual exam. They decided they were going to have an IUD inserted. You schedule the procedure. Sometimes these need to be pre-authorized by the payer, sometimes not. You schedule the procedure. If you've already made the decision to do the procedure, we're going to bill just for this service. The complications with IUDs is that often in a large group practice, not everybody does them. So there'll be a certain number, maybe you have a nurse midwife or nurse practitioner, women's health physician, or a family physician who does IUD insertion and removal. And so someone else will see the patient and discuss it, and then the patient appears on your schedule and you're doing the IUD insertion. Keeping in mind that the payment for a procedure includes explaining the procedure, getting consent for the procedure, doing it, and then giving instructions at the end. Many groups that I see do go through more than that. The clinician goes through more than that work if they've never met the patient before and they're about to do an IUD. But this is one of those gray areas. You want to make sure you're document, if you're billing an E&M, a level of service with it, that you've documented that pretty carefully. There's a code for pessary fitting and insertion of a pessary or other intravaginal support device. So you see a patient, she has a retrocele or a cystocele, and this is the plan. If you are able to do it today, that is, you don't have to get it ordered or pre-authorized, then you bill for both the level of service and for the fitting and insertion. If they come back to do it, you're going to just select this code. If you've purchased the pessary, we're going to charge for that as well. If a patient returns for removal, cleaning, and reinsertion, we just use an office visit code. There's no code specifically to describe the service of cleaning, reinsertion, and removal, cleaning, and reinsertion. If the patient has had a big weight change and needs to have a different size pessary because this one isn't working anymore, then you can bill for the 57160 again. There are a lot of colposcopy codes. There are about 8 of them. This is the one done most frequently, 57454, colposcopy of the cervix, including the upper adjacent vagina, with biopsy of the cervix and endocervical curettage. There are additional colposcopy codes if you do a colposcopy without biopsy, or if you do just the biopsy of the cervix, or just the endocervical curettage, or with LEAP. So you select the one that you're doing. And there's a new code in 2021, add-on code. It's got that plus sign in front of it, 57465. Computer-aided mapping of cervix uteri during colposcopy, including optical, dynamic, spectral imaging, and algorithmic quantification of the acido-whitening effect. I don't know if you have, I've never seen that build. It's brand new. But it is new. It's an add-on code to colposcopy. Now I'm going to talk about repair codes, and repair codes are done most frequently in urgent care centers and in the ED. I hardly see them billed in primary care anymore, but in case you're working in an urgent care center, I'm going to go through them pretty briefly, especially just the first 2. None of us are doing complex repairs in the office. So repair codes, laceration repair, we're not repairing my ripped shirt, right? Laceration repair is divided into simple, intermediate, and complex repair. And then it's defined by location in the CPT book. And each of the three, simple, intermediate, and complex, have different locations defined. So simple repair, it's primarily the epidermis or the dermis or the subcutaneous tissue, closed with a single layer, doesn't involve deeper structures. It includes local anesthesia if you need it, or cauterization of the wounds not closed. If you're using adhesive, you can count that as simple repair. It doesn't just mean stitches. Using one of those butterfly closures doesn't count, but the adhesive itself does. And for simple repair, it's defined by 2 locations. And that's important to remember what the locations are. Intermediate repair is a layered closure. So in addition to it requires more than just the simple closure of the skin and the subcutaneous tissue. It's deeper than that, included into the fascia, in addition to the skin closure. And it can include single layer closure of heavily contaminated wounds that have required extensive cleaning or removal of particulate matter. So that patient who's out riding their bike and falls, and you're going to do a laceration repair, but it's got a lot of gravel or dirt in it. Document the contamination and that requires your cleaning or removal of that. And then that counts as an intermediate repair, even if it's a single layer closure. They added the words that are highlighted in yellow here. It includes limited undermining. And now they've defined limited undermining for us. Defined as a distance less than the maximum width of the defect, measured perpendicular to the closure line along at least one entire edge of the defect. I admit this every time I do this definition, I flunked geometry. I have no idea what that means. Now, there is a picture in the CPT book, and I'd be happy to send that to you. And I do tell the story when we were still out and about and traveling. I was with a group of fellow consultants, and we were at dinner. This is what we talk about at dinner. And I said, I cannot understand what that is. And they got out their silverware and showed me what it meant. But there were 2 of them were nurses, but I still, we'll help you with that, with the picture, but I'm sure that that means something to the clinicians. Here we've got 3 locations instead of just the true. And when we're thinking about repairs, we're always thinking about length and location. Those are the 2, length, location, and depth, whether it's simple or intermediate. We're not going to worry about complex repair for completeness. You know, I had to put that in there. And complex repair has 4 different locations. But what we want to remember about repairs is repairs of the same type and location grouping are added together and reported with a single code. So if it were a simple repair where extremities and trunk are in the same location grouping, and you repaired 2 centimeters on the arm and 5 centimeters on the trunk, that's big. 3 centimeters on the trunk, you add those 2 together and you report 1 simple laceration code of 5 centimeters. If one was on the arm, simple repair of 2 centimeters, and 1 centimeter on the cheek, then we don't add those together because those locations are different. All right, everyone's favorite cerumen removal. So there are 2 codes for that. 69209 is for ear lavage by the staff. It doesn't have any, it is for when that is the only treatment needed to remove the earwax. 69210 requires instrumentation by the provider. You can't bill both of those together. But if the staff member does lavage and all of the earwax doesn't come out, and then the clinician goes in using a microscope and curette and removes the remainder of it, then we bill just 69210. We don't bill both of them together. The medical necessity for cerumen removal is listed on the bottom of this slide. So this is what you want to document when you're either having your staff do lavage or whether you yourself are doing cerumen removal with instrumentation. Visual considerations, you can't see the tympanic membrane, it impacts your exam. Qualitative considerations, hard, dry, irritated, painful, hearing loss or itching. Inflammatory considerations associated with odor, infection, or dermatitis, or quantitative, it's obstructive or copious. So you're going to document one of those things when either your staff member is doing the lavage. So in your exam, you note that, and then the staff member does the lavage, or before you do the more extensive code. Now, these last 4 slides are probably services that we hope are being done by podiatry. So I'm going to go through them relatively quickly. It is pairing of or cutting of lesions, so a corn or a callus, single lesion, 2 to 4, or more than 4. Now, Medicare, Medicaid, and the payers believe that routine foot care is a non-covered service. So they say if you need to get your corn treated or you need to get your nails cut, that's considered routine foot care, unless the patient has certain diagnoses and conditions. And I'm going to go through those conditions in a minute. But this code on a patient without those conditions is a non-covered service. As is nail debridement by any method, and that is 1 to 5 or 6 or 4. It's got to be medically necessary for the clinician to provide the service. It would need to be dangerous for the patient or present a danger for the patient to be able to do their own nails because of risk of making an unintentional wound, bleeding, and then a non-healing wound. There are frequency limitations every 60 days. Try and do it every 59 days. So we've got to make sure we watch that. And then we're going to use modifiers and diagnoses to establish the medical necessity. And you don't have to remember these modifiers. Revenue cycle will help with the modifiers. And in podiatry, they know them by heart. So Class A findings, non-traumatic amputation of the foot or an integral skeletal portion thereof, obviously. Class B findings, absent pulses, advanced trophic changes, evidenced by any 3 of the following: decreased or absent hair growth, thickened nails, discoloration, thin or shiny skin, rubor or redness. Class C findings, claudication, temperature changes, edema, paresthesias, or burning. And in order for this not to be considered routine, the patient needs to have one of these: Class A finding, clearly, or 2 Class B findings, or a Class B and 2 Class C findings. And so what we would want in the event that you were doing nail debridement for some reason, or treating a corn, shaving a corn off, you would want to be documenting something that you see here to show the medical necessity for you performing that service. So something from Class B or Class C, or Class A, of course, but those are the things that you would want to document in your exam. Paresthesias or burning are obviously what the patient tells you, not something you see on exam, but you would want to be documented that the patient says that they have burning in their feet or whatever. And then some of those are findings that you see on exam. You would want to be documenting those in the record and then choosing the correct diagnosis codes. The patient has peripheral neuropathy, peripheral artery disease, diabetes, whatever those conditions were. And then revenue cycle will help you with the modifiers as long as you're documenting either the history or the conditions so we can find out which class findings they are. All right, I have come to the end early today, but I am happy to take questions in chat, or if you wanted to unmute and ask a question, I'm happy to answer them verbally too. And I see Lynn's on the line. Thank you, Lynn. It's always a help when you have a fellow coder on the line, and she can help me out if I get stuck here with something. I did put the handout in chat. I don't know if you're able to download it. Someone told me before they couldn't, but I put it in chat in case you needed it. And, you know, please contact your manager if you need it and you didn't have it.
I have one question.
Yes.
It's Amanda Santiago, a nurse practitioner. I do Nexplanon placements. Do we do just a procedure note for that? Or are we also doing, I don't know if I missed that part, but do we do an E&M and the procedure note or the procedure code?
So when you're doing that, have you seen the patient at a prior visit and made a decision to do that? Or are you talking about it and doing it today?
I would say sometimes both. Sometimes they've had a phone visit with somebody else and then they get onto the schedule. And other times they've just called and said, I want to get an Nexplanon placement in. So then I typically will go over everything anyways, but sometimes they have already talked to somebody, but not always.
But they've decided that's the procedure that they want to have. That's the method of birth control that they want to use.
Yeah, typically, yeah.
Yeah. So I would say this is one of those, it's not always or never. If you've seen them before and talked about it, maybe at their annual visit and then schedule them to come back and do it, I would bill just for the procedure. If they're your patient and you're talking about all the options with them, and then that's what they decide, I would bill for the E&M service and the procedure. For the other ones, it's really very gray. If what you're doing is explaining the procedure, what's going to happen, if you're documenting informed consent, you're doing the procedure, and then you're telling them what to expect afterwards, I would bill just for the procedure.
Okay. Thank you.
Betsy, did I miss you going over the modifier 25? Because I didn't hear you today go over that.
So I talked about modifier 25 very briefly at the beginning, and I talked about the issue about whether we would bill both an E&M service and a procedure, or the procedure only, and quoted from the NCCI manual. So I did do that at the very beginning of the session.
Okay, excellent. Thank you.
You're welcome.
That is a point of contention always for clinicians to make that decision. And I'm happy to help you if you need to Skype me or anything during the procedure. I've done that for other clinicians all the time, just to clarify while you're charting. That would be great.
Yeah.
Okay. Okay, thank you.
All right, everyone. Thank you. I appreciate you sticking with me through all 5 of these presentations, and wish everyone stay safe and healthy.